I'm Terrie Hastings, and this is a partial fulfillment for requirement for teaching and learning strategies through the University of Texas for the master's program. So I'm going to talk to you today with my clinical nurses about clinical incident analysis, and this tool is used for reflective learning. So I have here Caitlin, Beth, and Gabby, and they're my clinical nurses, and we're going to kind of evaluate a situation, an event. So Gabby's going to go over the event, the narrative, on a patient that she had on a med-surg floor.
An 18-year-old female came to the hospital after a gunshot wound to the right ankle. She was taken to the OR immediately upon arrival to the EC. Post-op, the patient presented to my ortho trauma unit on the evening around 7 p.m. She was arousable when she was brought to the floor, and her mother was with her at the bedside. I checked her in and got her vital signs right away. Everything was within normal range based on her age and previous reports. I asked her what her pain level was, and she responded an 8 out of 10. I checked her MD orders for pain management and saw that she was to receive IV Dilaudid for moderate to severe pain. I went ahead and gave her 1 milligram IV. This was around 8 p.m. I checked on this patient a little more than an hour later, and she was sleeping. I noted her snoring slightly, and her mother said that she snores at home as well. I received a report at midnight on her vitals, and they were not concerning. However, her blood pressure had dropped from 114 systolic to 102. Shortly after midnight, I came to her room to check on her pain, and I asked if she was still in pain. She did not fully open her eyes, however, she nodded her head to let me know she wanted more pain medicine. I wanted to stay on top of her pain, so I gave her another 1 milligram as ordered by the MD for moderate to severe pain. I stuck my head in the room around an hour later, but I did not wake her up. Her mother was asleep at the bedside, so I noticed her breathing and left. At 4 a.m., the clinical tech notified me in alarm. She said that she could not arouse the patient, and her blood pressure was in the 80s. I went to check on her and had to call a code. We had to intubate the patient and send her to the medical ICU for ventilator monitoring. I found out later that this patient suffered hypoxia and should have been assessed for sleep apnea due to her history of snoring.
Thank you, Gabby. I know sometimes when you have a patient that goes bad, it's pretty emotional. So we're really looking at this to help everyone to learn from it. So we're going to go through this, and we're going to use the A3 form for our workout process so that we can identify what the trigger was, the situation that we want to try to improve upon, and then do a gap analysis, look at some goals, and maybe improved outcomes from this, okay? So we're going to use this tool. It's the A3 tool. And so let's talk about what the theme is here. What is the unanticipated event that happened?
The patient became hypoxic.
So we had a hypoxic patient. Very good. Okay. All right, so let's do a little background on that. So the patient came from the OR. We didn't know that she was respiratory compromised patient. She was a young patient, right? And so a lot of times we don't put those two together. So we had an unchecked OSA patient, okay? And then tell me a little bit about Dilaudid. Is Dilaudid something that we need to look at closely? Patients, what do we need to monitor them for?
Respiratory depression.
Right, so Dilaudid causes respiratory depression. Okay. Okay, and then also, so our current condition, the patient got probably wasn't assessed regularly after the Dilaudid was given. One thing that we probably could have done differently was neuro checks, and not just going to see if she was breathing, but really waking her up to see how she was neurologically. So So these neuro checks weren't really done appropriately. So our root cause analysis, what would you say was really the trigger for this?
Assessing for OSA in the beginning,
Right, increased
identifying her
monitoring. Okay.
situation for monitoring.
So lack of monitoring. Okay. So what is the goal we want here? What would be our target condition for this event, for this situation?
You want to control the pain but keep the patient stabilized,
Okay.
monitor them.
So we want pain control and a stable patient. Okay? All right, so how would we implement this? What are some steps we can take to make this happen, to be safer for our patient?
Whenever possible, the hospital could screen patients for OSA, and post-operatively, they could use the CO2 monitors to monitor patients that are on opiates for pain management and at risk for respiratory compromise.
Correct. So patients that we feel like are in a compromised respiratory state, we can do some increased monitoring at least for the first 24 to 48 hours post-op, when they're going to be getting these opioids, these medicines that kind of depress their breathing. Right. Okay, and how are we going to make sure that these strategies have worked, that they were successful?
Evaluate patient outcomes, not just one patient, but multiple patients.
Okay, and if we have a patient with hypoxia, maybe we could look and see what's surrounding the event.
Right.
Okay,
And reassess.
and reassess. All right, perfect. So at the end of this, some of the goals for this exercise was that you had a really good knowledge of this tool, critical incident analysis tool. Do you feel like you could use this tool now?
Yes.
Okay. Do you feel like there are situations you would feel comfortable knowing which situation the tool would be appropriate to use for?
Yes.
Okay. All right. Well, I appreciate you your input on this. Thank you.
Okay.